Waiting for our chair, but our first debate, which we ask, can we de-escalate axillary surgery for or TAD or SLNB after neoadjuvant chemotherapy in patients with high nodal burden? This is very important. So the question is, can we de-escalate axillary surgery after neoadjuvant chemotherapy of high nodal burden? And we'll discuss subtypes and whether we do radiotherapy, adjuvant therapy. And we'd like to show you to vote now with your voting devices, whether you'd be happy to de-escalate axillary surgery in this situation with high nodal burden. Let's say patients with more than 4 nodes initially, or let's say advanced disease initially, so clinical N2 disease initially, but high nodal burden. So if yes, you think you can de-escalate, please vote yes. If you think no, we can't de-escalate, we must do axillary clearance, then please vote no. And once you've voted, then we'll do a vote at the end. Now, whilst you're voting, we have 2 speakers. We have in the room Andreas Karakatsanis saying no, we cannot de-escalate. And virtually, and I'm not sure if we can see or hear Thorsten Kuhn, Professor Kuhn from Germany, saying yes, we can de-escalate.
Thank you. Good morning.
Nicolo, good to see you.
Good morning, everyone. So I will co-chair together with... can you hear me? Okay, yes. Good morning, everyone. I will co-chair together with Peter this session, so we can now see the results of the first vote. I see that there is quite a good number of you that would de-escalate surgery in patients with a high nodal burden. I don't know if the vote is now closed or not. Yes. Okay, perfect.
78% yes and 22% no.
Perfect. So 78% in favor of de-escalation. So we will see the point of view of Andreas and Professor Kuhn, and then we will vote again after.
So Professor Kuhn has the upper hand to begin with, and here's Professor Kuhn. Torsten, good morning to you.
Good morning.
Good. Hi, everybody. Kalimera.
Torsten,
yes.
Did you see the vote? Did you see the vote? You're
Yes.
already in advantage.
Yes, I'm happy with it. Can you hear me?
Yes.
Okay, perfect. I'm very happy with the vote, and I only can't lose against Andreas, who is a very strong opponent. So first of all, please accept my apologize for not being with us. I would have liked to be with us today and see all my friends in Greece, but I had an overlap with the family history, so unfortunately I cannot be there. So should I start with my pro discussion?
If you feel you still need to speak, then that's fine. Yes, thank you.
Okay, so question is, can we de-escalate axillary surgery in patients with high nodal burden? These are my disclosures. And let's first of all define what high nodal burden is. And we have the UICC and AJCC classification, classifying CN1 as ipsilateral axillary mobile nodes, CN2 is matted or fixed node, and 2B is additional internal nodes, and 3 is intraclavicular nodes. But there is also a clinical classification that is used by many surgeons, and this relates to the number of clinically involved nodes, and more than 3 nodes are considered as high nodal burden. So in the somehow milestone study, the Sentinel, the ACOSOC study, the high nodal burden was not really included. So in the Sentinel study, we did not differentiate between CN1 and 2, and in the ACOSOC study, only 10% had N2 disease, so we do not have really information on false negative rates and the accuracy of sentinel lymph node biopsy in this setting. However, in the meantime, X-ray staging or less extensive X-ray staging has been refined by removing more to sentinel lymph nodes or using a combined technique or marking the most suspicious load with some kind of marker. However, in many guidelines, such as the German AGO guidelines, clinicians are still still discourage performing target axillary resection with patients with more than 3 central lymph nodes. You can see 1 to 3, we have a positive recommendation, but for patients with more than 3 lymph nodes, target axillary resection is discouraged. So why is this so, and what are the concerns related to central lymph node biopsy or target axillary resection in this setting? So first of all, certainly under treatment by false negative staging and missing residual disease, non-PCR, and potentially undertreat the patient with potential worsening of survival in triple negatives and HER2 positives, or to have regional undertreatment and overlook positive nodes leading to more regional failures. However, this is a meta-analysis now published in 2021 comparing false negative rates for central lymph node biopsy in N1, N2, and N3 patients. And astonishingly, the false negative rates in the N1 patients was 14%, and it decreased with higher nodal burdens, only 6% in patients with N3. Although you might argue, okay, these were retrospective studies, and patients' numbers were low. However, these are the available data. In the important RISAS trial from the Netherlands that assessed the accuracy of target axillary dissection in N+ patients, 27% of the patients had N2 and N3 disease. The overall false negative rate was 3.4%, and the false negative cases in patients with N2 and 3B was so low that it could not even be assessed in the trial, as the authors stated in the publication. In addition to that, what we saw in the AXANA study, that in the large majority of patients, the non-PCR is determined by the response in the breast and not the axilla, and only 5.8% of patients have complete response in the breast, but are detected as non-PCR by axillary staging. So false negative rates are comparable between N1 and higher end stage, even a bit better in higher stages. And systemic treatment is mainly driven by response in the breast, so there's not a real danger of systemic undertreatment. Now, what about regional failures? And this is the NeoCentiTurk study that included N1, N2, and 3 patients, and 18.9% had CN2-3, and 37% of the patients had more than 3 suspicious lymph nodes, and there was no difference in regional recurrences comparing patients with CN1 and higher CN stage in the upfront setting. Now, if we look, this is another study that focused explicitly of patients with high nodal burden, defined as more than 3 lymph nodes at PET-CT, with a follow-up of 44 months. And again, it was shown that there were very, very few recurrences in patients who initially had clinically suspicious, had initially a high nodal burden. So is there a risk of regional failure? No. Patients with CN1 disease were not included in B51, so you do not even risk in undertreatment by false negative staging with regards to radiotherapy. And all patients with high nodal burden are candidates for regional therapy, so you will not miss patients for adequate regional therapy. In addition to that, axillary resection, high nodal burden, you always have to consider that with higher nodal burden, the involved lymph nodes are increasingly located outside of the reach of axillary surgery. So what sense does axillary dissection make in patients with high nodal burden? And therefore, I absolutely confirm what the majority of participants in the audience said. Can we de-escalate axillary surgery? This is a very clear yes, we can. Thank you very much.
Well, thank you, Professor Kuhn. Now we go on with Andreas, but it will be a hard part for you now.
The hardest, can you hear me? No. Can you hear me now? Yeah. I have to sound close and sexy. Okay. The hardest part for me is that I have to debate on something that I do not personally believe in, but we'll see how that will go. Anyway, so this is me and this is my disclosure. Whenever I get a debate, I really need to look at the question, you know. So we need to take terms. And Torsten did a lot of the work for me. Let's think logically here. Primary systemic therapy and adjuvant therapy, if prescribed without any type of adaptation, they will have the same survival. But we know that primary systemic therapy will enable immunotherapy, which is completely ineffective if given in the adjuvant setting, and will allow us for the HER2-positive and triple negatives to select postoperative treatments, and in a few months' time from now, hopefully, same for luminal-like cancers, and it will sometimes lead to the de-escalation of treatments. The big thing is that de-escalation of treatments, both in the breast and the axilla, have been an en passant finding. So there is no actual randomized control trial that looked into response and then randomization. And I believe that it has not been done for a good reason. I do not believe that a trial like that would be feasible. But let's take turns a little bit. So in terms of treatment guidance, what we actually know is that our data on how to deal with surgery is observational. And I know that Torsten went for the Turkish study. I went for the German study, the CENTA here. And what do the asterisks mean? That pending ATNEC and Alliance results, what we have is actually some data sets on, at best, prospectively registered material. The ACOSOG falls completely out because all patients had an axillary lymph node dissection, so you cannot make any claims about survival with regards to that. And if we look at the 38 patients with clinically N2 disease that were included in the ACOSOG study, you have a 0% false negative rate only for the 8 patients that had a complete pathologic response. Overall, you have a 19.2, and nobody would be happy with that, and you have a detection rate of 89% approximately, and nobody would be very happy with that either. Now, high nodal burden is not the acquired taste of counting nodes on radiology, because this is completely arbitrary and completely outside of how the studies were made. We heard from the first author of the Sentina trial, which is my opponent in this debate, that the Sentina, they did not report it separately and they did not consider that, so we do not have any data about that. The data from ACOSOG is completely scarce, and the data from RISAS as well is the same thing. It has not been addressed, and it has not been prospectively declared either. So high nodal burden should be clinically N2 or higher. If we are discussing the three nodes radiologically is where one would start from, and this is where we went to begin with back in 2020, I believe, when the Lucerne Toolbox said that, because the idea is that if you want to start from somewhere, start from these ones. Now, NSABP B51 made a very clear difference because they said clinically N1, so that kind of dissolved any type of inaccuracy about that. And high volume nodal burden means two things. You either have somebody who continues to be clinically node positive after neoadjuvant chemotherapy, or you have somebody that has clinically and radiologically converted. Now, to avoid axillary lymph node dissection in those that are seemingly node positive after neoadjuvant chemotherapy, I have gathered all the evidence to show you, and this is the evidence. Here you go. This is the evidence to not do an axillary clearance. Now, going back, I will not dwell on this slide because Torsten showed it. What do we have for evidence? Yeah, well, what do we know? Again, we know that this has not been adequately addressed. We do have a study from the MD Anderson, the extended work that they did at the MD Anderson showed that in good responses you have an acceptable false negative rate and good outcomes in detection when you do a TAD but not a sentinel node. But we do not have any survival data. We do not have given survival data. Now, Torsten made a very fair point about what do you gain if you have more nodes that are outside your excision field anyway. But if we go a little bit closer to that, the idea is that we could or could not de-escalate, since the NSABP B51 did not include those patients, so they will be getting radiotherapy anyway. But what we do not know in terms of evidence at all is whether those two treatments are interchangeable in this clinical setting. So do you really have data that supports that omitting axillary dissection and giving radiotherapy instead is something that makes things better? I would argue against that. And the reason for that is that uncertainty is very clear in this field. We do not know, as I said, whether they would be interchangeable. And I would like to just bring your attention to two things. We have had a recent exploratory analysis from the NSABP B51 and some data on the Supremo that said that those patients actually did worse when they were irradiated. And the big question is omitting an axillary clearance in a potential state of interchangeable scenarios always better and going for radiotherapy? I think that this is not necessarily the case. Having said that, do I like doing axillary lymph node clearances? No, I don't like doing it, but I need to be able to do it, and I need to be able to do it well when needed. And until now, the major argument here is that we do not know that it is not needed. Thank you very much.
Right, so we've heard from both our speakers, brief, to the point, evidence-based, and so we'd like you to re-vote now the same question: can we de-escalate for CN2 and above? Yes, if you think like 78% thought beforehand, and Torsten is correct, and no, if you are swayed by the second argument and you think we cannot de-escalate. Well,
61%
61.
39%.
So Andreas convinced some of you.
so we had a swing of 17% for Andreas. So, well, that's a great result. Any questions or comments from the floor?
I see one. There is
Bah-
Badir Guloglu.
Thank you. I would like to just, elaborate the so far evidence about this axillary dissection thing. I know Andreas is pro on this de-escalating thing, so this is not a, statement against him. But there is an uncertainty about the efficacy of doing or de-escalating axillary surgery here. But there is some certainties. We are not just looking at the efficacy of what we are doing in our patients, but also the consequences. So there is one certain evidence, is that when you do axillary dissection, you have lymphedema. So it's worse than de-escalation. The second is probably its cost effectivity and probably the satisfaction of our patients. So only focusing on the efficacy for now is not a correct thing, I believe. So we need to consider those three other things before saying that this is an uncertain thing. No, there's a certainty that it causes some consequences. And what we rely on, this historical evidence, we assume that axillary dissection is superior. We assume it. There's no proof that it is superior now.
Yes.
Agree completely. Now, with regards to that, if we kind of think the role of the extent of surgery, the NSABP B04 was published when I was 2 years old. So this answer has been given. We will not find much more with regards to that. The idea is to be able to discuss and debate on how we will be looking into things, into zones that are still data gray in some sense. If you would ask me, I would not routinely do it, and I'm not happy when I have to do it either.
Yeah. Andreas, one question also for you, for both of you. So, but do you think we really run the risk of under-treating patient if we do not complete axillary dissection in these N2 and 3 patients? What really drives the choice of systemic therapies?
The way I see it, and we had a discussion about that in the morning, you already know early on during the monitoring of primary systemic therapy if something works or not. You have a post-second cycle PET, and there are these cases where everything has disappeared and it has actually disappeared, and then you can feel free. I mean, you see the TRAIN 3 study from the Netherlands, and they are de-escalating systemic treatment based on that. So if we can dare to do that, we could be able to de-escalate. And I firmly believe in something else. Torsten pointed it out very beautifully. If I've got a CN3 patient with things that are completely outside our standard resection field, what are we accomplishing by doing an axillary clearance, a standard axillary clearance that still fails to remove?
Yeah.
We know that these patients will benefit from radiotherapy, they will benefit from more systemic therapy, putting them into the risk of more surgery. And with the latest trends, having very eager plastic surgeons that will complicate an axillary clearance because they will want to reconnect the lymphatics with not very clear benefits until now. So you take an operation that is in itself of doubtful value, and instead of 20 minutes, you make it into a 3-hour operation.
Yeah.
How does this serve the patient best? I think it doesn't. I don't know if Torsten has something to add on that.
Yeah.
Yes, well, I agree entirely with you, and I think we all think the same thing. So, because as I pointed out, the decision for systemic treatment is made according to, there's PCR and non-PCR, so there's not much burden to less burden, and the PCR is determined in 95% by the breast PCR. And we saw data on retinal recurrences, so we know it. We have several studies. I saw there's even one study that I showed the data that explicitly assessed high burden with low recurrences. Therefore, for me, I'm really convinced, and I think we all are convinced, that axillary dissection, and as Vaidi very nicely pointed out, we always have to consider that axillary dissection is associated with a lot of morbidity, and we have to take this into account and really we should prove where's the benefit of axillary dissection.
And I think that we should stop counting nodes.
Yeah.
It is conceptually wrong. It is not evidence-based. It just overstages patient, that it will condemn more to unnecessary upfront axillary clearances following surgery.
Yes, I totally agree that this could be an overstaging, counting nodes. Yes,
Well,
it's not.
In practice, what actually happens is that there is no consensus on how to do that. So what you do is that you have done a biopsy in the breast, or 2 biopsies in the breast, you have done a biopsy in the axilla, and then you do a second look ultrasound or MRI, and nodes are swollen because that's what they do when you biopsy the breast. They get swollen.
Yeah.
So all of a sudden, they say, oh, 4 nodes.
Mm-hmm. There is a question from Sophocles.
Well, thank you very much for this debate. It was very well organized. There are a couple of technical considerations. First of all, primarily, if you have a bulky disease, which is definitely a high nodal burden, when do you mark the lymph node? In the beginning or after a couple of cycles of chemotherapy, and seeing whether you have a response, and then you put the clip in?
What we do is that we tell the radiologist that just put a clip in the most prominent node. Now, when we're talking clinically
If you have a bulky,
yeah, you put it in the bulk. I think that what defines our expectations in that setting is biology.
Okay, so the second technical consideration, how do you assess the response? I mean, you will never get
the way that you would assess it for any other reason. Formally, if there is no single best hands down radiological modality, but out of the available, if you want to look at axillary response, especially in the locally advanced cancer that has a 46% risk of having distant metastases, you should be doing a PET CT for this patient. So it is the PET CT that will give you the answer. We know from Mario Lang-Schmidt's meta-analysis already in 2020 that the MRI is as good as the ultrasound is, and the ultrasound is very bad, so the MRI is very bad. You should not look at the MRI to evaluate axillary response. If you want to see metabolic response, which you need for the aggressive subtypes, you go for that. And it has to do with patient expectations. If they're interested in something like that, you have to form the expectations, but response, we know it is biology driven. It is not more than that.
No, I totally agree on that, but my question is, how do you select the patients, saying that this patient is candidate for TAT because he had a complete something response?
My personal preference to that is that I think that we should ask radiologists to clip as good practice, because I think that since we're very fast coming towards the era where ctDNA or microRNAs will be biomarkers to assess response, you just do it for everybody in good practice, and you will have a combination of evaluation as you go with neoadjuvant chemotherapy. Now we have the DESTINY results. In Sweden, we are running the Ariadne trial, which is biology tailor-based for HER2 cancers, and I can tell you, patients randomized in the Enhertu arm, you see all sorts of crazy things disappearing. So the idea is that we will learn as we go, but the response is always biology and treatment driven. We need to stick to what we have done in terms of marking and finding the optimal way to assess that. Usually we know that early response radiologically is the one that comes with higher levels of complete pathologic response, right? We have known that for the last 12 years, yes. I guess. So that is probably the best way. It is to monitor early on and then to tailor out from that.
Thanks.
Thank you. Just one last question. What do you think, Peter?
Last question.
Hi, an excellent presentation, both of them. A simple question. In case of a HER2 patient, HER2 positive, and complete response after NACT, we can feel secure removing a small piece of the breast instead of the whole fundum of the primary tumor, but we still need to remove the whole axilla. It's a simple question.
I think that Torsten has answered that. I mean, having insights into 5,000 patients from the Sentina is valuable, of course. And I think that the message was clear in that it is breast response is very tightly associated to axillary response or expected axillary response. Torsten, do you have any comment on that?
No, I don't know whether I got the question correctly. But I think mainly response is determined by the breast. Yes, this is what I said. But maybe I did not get the question right.
Yes, the question.
Yes,
okay,
the question is: we feel secure after a clinical complete response to remove a small piece of the breast, not the whole primary footprint of the tumor, but we feel secure to do it, and I agree. But we don't feel secure to remove a sample of the axilla. Of course, I agree that we don't have to remove the whole axilla. But the question is, if we feel secure to remove a small piece of the primary tumor, of the fundum, of the footprint, why shouldn't we be sure or secure to remove 1 or 2 lymph nodes?
I think we probably agree entirely.
Yeah.
Thank you. We'll close the session now and move on to the next debate.